Hello, everyone. Today we have with us Dr. Sowmya Nagaraj, who's a pediatrician and an allergy specialist in Bangalore. Welcome, Dr. Sowmya. Thank you for taking the time to be with us.
Thank you, ma'am.
Thank you. Today we will be talking about some aspects of urticaria, especially in children.
Yes.
So, Dr. Sowmya, can you please tell us what exactly do we mean by urticaria?
Urticaria is a very common pediatric disease, very common we see in pediatric practice and mistaken for most of the other diagnoses. Generally, urticaria is very determined as it is just lasts less than 24 hours. It does not leave any mark behind and very well responds to antihistamines. And I think very commonly we see this in pediatric population, but mislabeled for various other diagnoses as well.
Right. So, what exactly? There should be some triggers for it. Can you please tell us some of the triggers which can induce urticaria?
Yeah. So generally, I think in urticaria, common terminology we use it as hives, and it is of two types: acute or chronic. Generally, acute lasts for less than about 6 weeks, and chronic could be more than 6 weeks. In children, acute urticaria is very commonly seen post-infection or with infections, and most of them are self-limiting, takes about 2 weeks and less. The other triggers could be food, insect bite, drugs. We have specific history for that. And in a chronic urticaria, which is beyond 6 weeks, the role of allergy testing could be limited, but it is mostly idiopathic or physical urticaria, such as pressure, going out in excessive heat or cold, that could be trigger factors.
Right. Thank you so much for differentiating between acute and chronic and the triggers being different. This also, we talk about angioedema. Can you please, what exactly do we mean by angioedema and how to differentiate it?
That's a very important question, ma'am. So I think angioedema in urticaria, it's a very common association, and it is usually a more deeper involvement of the tissues like dermis or epidermis. Epidermis is mainly involved in urticaria. This is intradermis, and it is usually swelling of the mucous membrane, such as the lips, eyes, or fingertips. And in urticaria patients, at least in chronic urticaria, we have 40% of the patients who are associated with angioedema.
Okay.
As you rightly said, ma'am, I think it's important to differentiate between urticaria, angioedema, which is probably more concerning or not. I think in angioedema, if it is responsive to antihistamines and associated with urticaria, we generally probably relate it to more of allergic etiology. But if it is only angioedema, that is the point of concern.
Right, right. Thank you so much for telling us that almost 40% are associated chronically, chronic urticaria is associated with angioedema. I think that's a very important point which we have to keep in mind and probably look out for. Yes. So, moving on, can you please tell us some of the diagnostics which are needed and how useful are they?
Thank you, ma'am. I think that's a very important question. Most of the parents, when they present to us in our pediatric OPD with hives, they're very concerned, especially with the skin angry looking and incessant itching. They're worried, is it a food trigger or anything? Should we do any blood tests or not? Sometimes if the history is associated with some infection, it is just reassurance telling them that we may just need to continue, have patience. But if there is an food trigger in the history which is determinative, or some drugs or insect bite, in acute urticaria, there is a role for allergy testing by the form of skin prick test or a serum specific IgE, depending on if they can stop antihistamines for a certain period of time. Most of the patients in chronic urticaria, we may not be able to find the triggers because it's mainly physical triggers or spontaneous urticaria. The role of testing in chronic urticaria would be less. That we see more in adolescent or young adults. So there we may have to do some autoimmune workup, especially anti-thyroid peroxidase antibodies. But in acute urticaria, we may have a role for allergy testing. But as I said, ma'am, probably about 80% of our acute urticaria is self-limiting and post-infections. We may not need to do much tests. Probably reassurance and frequent follow-up for the medicine step up or step down would be quite helpful.
Thank you so much for elaborating the tests and where exactly it is used. So as you mentioned, most of them really may not need any testing. So that's something which we have to keep in mind. And how do we manage these cases?
I think I think oral antihistamines, second generation, still remain the mainstay of treatment. Uh, the concern is, how long can we give? Are they safe or not? We have found that in clinical practice, second generation are quite safe, longer period of action, non-sedating. I think we have to just reassure and give them a good optimal dose. If needed, we can go up to fourfold the normal dose of the regular antihistamines. Many a time we see prescriptions of oral steroids along with antihistamines. I think if we give them an effective dose of a single antihistamine, the need to use oral steroids would be definitely less. You have to just reassure saying that skin looks very angry, concerning, but internal organs would be absolutely well. So I think they remain the mainstay of treatment.
Right.
Very rarely we may have to go to other treatment options.
Okay, so that's really reassuring to hear that most often the second generation antihistamines are adequate. Any role of local application topical, because parents do ask something to calm the skin, as you mentioned, the skin is looking angry, etc. So
very important, I think, practical point, ma'am. So I think the role of a topical steroids would be very less here, because we see that in the practice also some topical steroids. Calamine lotion is one thing which is very commonly prescribed. It's a very good topical application. The only concerns is once it dries up, it irritates the skin more and causes rebound itching. So I think that's why probably more moisturizer or an aloe vera based topical application would be still good enough with the moisturizing. Calamine, I think, because it causes sometimes rebound itching in some individuals, it may not be much helpful.
thank you, Dr. Sowmya, for explaining why calamine, because we do find that it's probably a baseline usage and a lot of our practitioners do use. Thank you. Finally, what about prevention? How can we take, steps to prevent urticaria in the future?
Uh, very important and practical questions which is asked by parents in our day-to-day practice. I think if it is acute urticaria, as we say, it is post-infectious, we usually tell some few avoidance measures, uh, like avoid hot water bath because it washes away the essential moisturizing factors from the skin. More frequent moisturizing, because that is underrated in pediatric practice, and give more emphasis on homemade food. So because sometimes food additives or colorings also
Right.
incite or worsen the pre-existing skin issues. I think giving them holistic approach, and especially in chronic urticaria, if the stress during exams, the children may stay awake for a longer time, or mismatch in the sleep cycle. I think addressing all those concerns would definitely help us reduce the intensity and the frequency of symptoms.
Thank you, Dr. Sowmya. Final question from my side. In your experience, how often do you come across recurrent urticarial cases?
Close to about 30 to 40% of the patients are recurrent urticaria patients, ma'am. And I think if we have missed somewhere along the diagnosis or emphasis on the appropriate skin care or pharmacotherapy, we do see these patients. Recurrent urticaria, I feel that in between episodes, these children do well, and again they come back with symptoms. Worthwhile in those patients, I would encourage probable further investigation. Though most of the patients in acute urticaria are self-limiting, and we may not need to do more detailed evaluation
Right.
for those patients.
Thank you so much, Dr. Sowmya. You have, really given points which are very, very practical in handling and managing urticaria patients. Thank you so much.
Thank you, ma'am. Thank you for the opportunity, and I hope this helps our fellow pediatricians at large to approach urticaria in office practice.
I'm sure it will be of great use. Thank you once
Thank you, ma'am.
again.
Thank you. Thank you so much.
Thank you.